the session will be streamlined on the phones for everyone, maybe those who have no access. You should tell it outside once more. Okay, streamlined through the app.
Okay, I have nothing to disclose, and this, as the floor looks like, it's a very, very hot topic. Now, all of you know this data from the ASMBS, the trends of a different kind of operations through the years, and as you can see, the revisional surgery is now the third most common operation in the United States. So the topic is really hot. Now, there are different reasons why you would like to revise a patient. There are, sorry, can we go back to, please? There are weight-related issues, so insufficient weight loss or weight regain, which is actually declining in the last couple of years due to availability of obesity management medications. There are very uncommon, absolutely uncommon indications like recurrence of metabolic comorbidities without weight regain. It's really exceptional, I must say. I've almost never seen it. And then there are complications, which is becoming the mainstay. Now, historically, insufficient weight loss and weight regain has been the workhorse of revisions, but that's clearly declining in the last couple of years. And because of the impact of obesity management medications on our clinical practice. What the new reality is that revisions due to complications, whatever we understand under the umbrella of complications, is increasing progressively in the recent years. Why this trend? Well, there is quite a lot of data about the efficacy of obesity management medications after metabolic bariatric surgery for weight regain or insufficient weight loss. And the bottom line is, first, it is effective. Second, even if we don't really do it, a lot of metabolic bariatric patients get on these medications post-operatively at some time. So a very, very reasonable algorithm nowadays, 2026, would be patient with weight regain and no other reason to revise. Start OMMs first, see how it goes, and in case of not insufficient response, then you may proceed to surgery. However, drugs do not treat anatomy. So whenever we have a complication that has an anatomic root, there is no way a medication is going to help. And actually, there are different kinds of complications. I'll try to be brief. So reflux after sleeve, malnutrition and metabolic complications after hyperabsorptive operations, and a plethora of complications, actually in relatively low numbers, after Roux-en-Y gastric bypass. Now, regarding sleeve, now we all know, and Gerard just had a session 1 hour ago where this topic was really eviscerated completely, is really an issue of the sleeve, both in symptomatic patients as well as in asymptomatic patients. Esophageal issues are an issue. And there is the French study, just to be very, very brief, that shows a high prevalence of esophagitis and Barrett's in 5 and 10 years after a sleeve gastrectomy. And the Spanish multicentric study that said that half of our patients had some kind of esophageal issues after sleeve at 5 years or more after the operation. So the take-home message is, this is a problem for sleeve gastrectomy. There is no way OMMs will be able to treat this kind of complications. Now, regarding Roux-en-Y gastric bypass, to be very, very clear, the incidence of complications leading to, isolatedly, to a revision that is pretty small after Roux-en-Y gastric bypass. And we all know that weight regain or insufficient weight loss after Roux-en-Y gastric bypass is a very, very difficult issue to treat. But we have anastomotic issues, strictures, marginal ulcers, internal hernias, that's a different topic. But in any case, those complications, ulcers especially, will need a surgical approach, not a pharmacological one. Now, regarding insufficient weight regain weight loss or weight regain after Roux-en-Y gastric bypass. There is a lot of talk about distalizing Roux-en-Y gastric bypass. The hard truth is that the predictability, I would say, the predictability of the result is a little bit in the stars. You can have you can have excellent results or very bad results. You can have very good weight loss and paucity of metabolic or diarrhea issues, or you can have both of the other way, insufficient weight loss even after a revision, and pretty hard metabolic problems. That's the one part. Second, whenever Roux-en-Y gastric bypass is distalized, we know from the medical literature that the risks are substantial. So postoperatively after distalization, there is a pretty high rate of hypoalbuminemia. There is a need for a further revision to shorten the biliopancreatic limb in up to one case out of 5, and there is even some mortality for protein energy malnutrition after distalization. And we cannot predict the length, according to the length of the distalization, what the result will be. We only know that we should not go below a certain length, because below a certain length, that's at least 300 centimeters of total elementary limb length, there will be an exponential increase of complications without a real gain in weight, in more weight loss. Now, there is another issue with Roux-en-Y gastric bypass that is related to dumping and to hypoglycemia. And in very rare cases, a total reversal of a gastric bypass may be needed. This is the Swedish series, which was just published, I think, less than 2 or 3 weeks ago in the British Journal of Surgery. And the indications were intractable malnutrition, chronic and severe abdominal pain, diarrhea, or hypoglycemia. And the point is that the clinical response to the symptoms after the revision, the reversal, was very good, but the risk of complications was pretty high. So it's not a joke, and this operation should not, the indication should not be put lightly. Regarding the more hypoabsorptive procedures, I'm coming from Geneva, so I have some experience with BPD, and we published a few years ago our 30-year follow-up of BPD patients, and the main result was that the need for revisions was present still at decades after the initial operations, and while the surgical complications tended to be less and less over the years, the metabolic complications tended to accumulate and be very, very prominent in the long term. Now, what can we do about the other hypoabsorptive operations? Well, it's a little bit early to draw on the same data, but what we can infer is that they seem to go on a very, very similar path, unfortunately. This is the series about revisions after studies, and to me, the very interesting part is the one below. So the highest risk was for the patients who were preoperative hypertensive and with a poorly controlled diabetes. So ideally, a very good candidate for SETIs. However, they had the highest risk for protein energy malnutrition and revision because, in my mind, they were the frailer patients. A very invasive, metabolically invasive operation should not be done upon a frail patient. Whenever you have to elongate, revise a hypoabsorptive operation, the goal is to increase the absorptive surface of the bowel. So basically, it's a shortening of the biliopancreatic limb and an elongation of the common limb and the alimentary limb. And regarding complications, this is a paper that was just published a couple of weeks ago in the obesity surgery, not from our centers, from a very high volume center in Italy. And it's about the complications after revisions of standard BPD. And the point is that the indications were mainly because of malnutrition, but also some cases of weight regain or combined reasons. But the complication rate was very high. 1 patient out of 5 had some kind of complication. In the end, the clinical response after the revisions was pretty good, although protein malnutrition could not be eliminated completely. Now, the risk of why are these operations high risk operations? Because there is a very high prevalence of hypoalbuminemia in these patients. That's a specific risk for complications. It triples the risk of sepsis it increases the risk of readmissions and reoperation and is associated with a higher mortality. So the key takeaways from this talk are GLP-1 receptor agonist medications, or OMMs, are changing the landscape, and it's likely to imagine that revisions due to weight regain or insufficient weight loss will continue to decrease. But the problem of anatomy is persistent, and there is no other solution other than surgery to an anatomical problems. Malabsorption problems, I think, are not over, even with the newer operations, and we should be really, really alert to what's happening to these patients in 10 or maybe 20 years' time. They're operated when they're 40, 20 years later they're 60, so they should still be productive. Please study these patients very, very thoroughly, because hyperalbuminemia is pretty prevalent, and it is associated with an increased operative risk. And even in the revisional setting, metabolic bariatric revisional surgery and OMMs are pretty complementary. You can tackle the problem from different angles, so they should be used in some cases, possibly together. So revisional surgery is a core component today of any metabolic bariatric surgeon in some way. Roux-en-Y gastric bypass is still today a very versatile operation, a very safe operation, and an operation where revisions for complications are not prevalent or not prevalent. Weight regain revisions are declining, as we said. With hypoabsorptive or malabsorptive operations, you get a Pyrrhic victory. You have very good weight loss results, very good resolution of metabolic comorbidities, but at a price that you should not underestimate. And revisions to complications are increasing in the last years, and preoperative or optimization is really essential to have the best possible outcome in a very difficult patient population. Thank you very much for your attention. That's my email for you.
Thank you very much. I think worldwide, we're all seeing a reduction in the number of primary cases, but thanks to our complications, we can all see we have more work to do.
We have a future as a revisional surgeons.
I have a question. And a very great talk, by the way, and it brings up a lot of questions. I'm going to ask Dr. Prager here, do you consider reflux after sleep a complication? And this is an important thing, because if it is a complication, then the number of reoperations put all together, if so, should outlaw the sleep to get as altogether because of the frequency of this complication, right?
Well, that's a very philosophical question, but obviously anything that deviates from a normal outcome is by definition Clavian from Zurich, a complication. Of course, Clavian, not all complications warrant the correction of the complication should be proportional to the risk of the intervention, be it medical or be it surgical, and the magnitude of the complication itself. So we all know that sleep is refluxogenic. I do not believe that all sleeves, patients who have a sleeve and have reflux will need a reoperation. Not at all. It's two different things.
We have time for one
The
more
minority
question.
will need a reoperation.
If we
It's a
don't have one,
complication.
I would ask Kelvin. Kelvin is maybe the most famous surgeon in the world for his hand-sewn gastrojejunostomy. And I know that you switched in the last years from bypass to sleeve. And Francesco said that bypass is the workhorse with low complications. So my question to you is, why did you change?
Well, you said we have got to move on here now, so no.
Short question, short answer.
Short answer is when we look at statistics and an isolated patient and a procedure, you're looking at two finite, right? You're looking at an endpoint. Well, it's not a finite, it's an infinite thing. The patient, you have to think of what's going to happen to this patient over the next 60 years, 70 years. And when you bring all that together, you don't want to destroy bridges. you want to be able to evaluate that patient, because we have no scientific method to say which operation is best for each individual patient. You know that they don't follow up, they don't take vitamins, they develop bad habits. I mean, there's a lot of problems with the bypass that aren't borne out in any studies that we see clinically. That's the short answer.
Okay. Francesco, thank you very much. And it's my big pleasure to announce Professor Rami Lutfi from Chicago, USA. He's the chair of the corporate committee of Big IFSO, a close friend, and I'm very happy that you are today with us, Rami, converting the sleeve, choosing between Roux-en-Y and one anastomosis gastric bypass.
Thank you. I have to take the word greatest selfie first to document the attendance of this incredible session.
This cost you 30 seconds.
Yes. So thank you. It's humbling to be in front of Calvin and Gerhard. These are my disclosure, but the most important disclosure is this. As an American, we were against OAGB for a very long time. So this is a group of us. You can see the doubtful look on our eyes. And then we met this guy in Vienna. And I watched Gerhard doing OAGB, and you see the look in our eyes, all changed, of course, except Nathan. But this is what surgery is about, keeping an open mind. And this is my practice today, and the only thing growing in my practice is medication. I have now 3 different people giving medications. OAGB is very small, and it's only because in America we have to go by insurance, and insurance, very few insurance now approves OAGB. Most my practice now is revision, just got over 50%, and probably now is about 65% revision. So just quickly, before the revision, for those who are younger in the room, make sure you get the patient records. Very important to know the history when it's not you who did the operation, and figure out, of course, after you know, is it for weight loss, the revision, or for complication. It's very important to understand, is this poor response, early plateau, or weight recurrence after doing well with the sleeve. Ask the patient why the patient regained weight, because patients a lot of time they tell you, actually very few patients tell you number 3, no idea. A lot of them, they will tell you think that they lost restriction, they're very hungry, and some of them just bad habits. You want to get those bad habits out of the revision, because they need to fix those in order for them to go to have successful revision. And the timeline is very important for people who had recurrence very quickly after surgery. You know, this could be either a technical problem or patient behavior, so you really need to figure that out. The choice of revision is related to the patient, what they want, related to the procedure, and of course in America a lot of time is dependent on their insurance, because we're bound by what the insurance allows us to say. And Calvin said it very well, patient understanding, compliance, and the vitamins, can they afford it, can they not afford it? I always say the length of the common channel inversely related to the patient intelligence. So if the patient doesn't get it, you really do not want to have, and thank you for what you said, great last couple of slides. You can make people lose weight by just simply shorten their small bowel, but then you get in trouble. And this is how we get bad reputation, by us competing how many points of BMI we should go under, and what is the definition of success. But to answer the question I was asked to answer, so this is how I think about it. So first, this is a normal sleeve. Actually, it's not a normal sleeve. It's above the diaphragm, but this is the only picture I can get in the airplane. So ignore the staple line. This is from Chile, from Camilo, I think, picture of his sleeve. Understand this. Why are you doing the procedure? So this is, for example, dilated fundus, and this is patient who may have come for loss of restriction, or this one for twist and has GERD, and this one for a stricture and has dysphagia. So your approach will be different once you understand the sleeve. So this one could be very easy, just like a Birath 2, OAGB. You cut the bottom of the sleeve, long pouch, and you connect the small bowel. Cannot get any easier. And then here, dilated fundus. If you don't have very bad GERD, you can re-sleeve that sleeve and then still do OAGB, opposite to what a lot of people in North America believe. We do that. Now, if there's a sleeve twist, you cannot do that. You have to have a small pouch above that twist, healthy pouch, and then you have to do Roux-en-Y, candy cane, Roux-en-Y configuration. The same thing for this patient who has stricture below. So Roux-en-Y is kind of the therapy, if you will, for problematic sleeves in the distal half of the sleeve. And this is how we think about it. You gotta do endoscopy to see. This is a patient that we got recently, and you look at the retroflexion, it's the surgeon never even touched that fundus. You can't tell this patient had a sleeve in the fundus, but the rest of the sleeve looks fine at the bottom. But a lot of time people say, the enemy of good is better. Don't go close to the spleen. But if you don't go close to the spleen, just remove the gallbladder. That's further away from the spleen. But if you want to do sleeve, you got to tackle this area. If you cannot, just don't do this operation. This is upper GI, and I will caution you when you look at this, just be careful, because this may not be dilated fundus. This is a talk that I gave in Naples. One of my favorite talk, they asked me to talk about twist, and I learned a lot about twist. So not everything looks like this is a structure, because you have to differentiate a twisted sleeve from a stricture. This is a very nice case report from Antonio that looked like just a dilated fundus, but then it was actually very twisted sleeve. And when you tackle things like this, you gotta be good at this. So don't do it if you're younger, because then you get stuck and not know what to do. This is, of course, the outcome when you excise that extra fundus and do gastric bypass. So to end and stay on time, this is our team approach. So we talk to the patient. Actually, we really get detailed history, and all our patients now see a primary care physician before they see me. So we really treat revision very seriously. I guess our appointment slot for revision is 1 hour for the initial consultation. And then you have to, of course, put these patients in 2 different pathways that are really pretty different. So if they are there for complication, you do upper GI and EGD, and then if there's a moderate or large hyoid hernia, it's very easy. You just have to do a bypass. It's just, if half the sleeve is in the chest, no reason to even think. So here, Roux-en-Y gastric bypass. Now, if there's no hyoid hernia, there gotta be some pathology, so esophagitis, we talked about stricture or a twist, and these people get treated medically. We really like to avoid surgery. And then if they're failure, you do Roux-en-Y gastric bypass. Now, we're very aggressive with endoscopy. We also have intraoperative endoscopy. And we, even if intraoperative endoscopy does not show, preoperative workup does not show hyoid hernia, almost always there's a little bit of hyoid hernia. So, and this is, I'm going to quote Gerhard Prager, if you're going to do an OAGB and you don't want to have a bunch of people with reflux afterward, like a lot of the literature, just investigate the hiatus and do intraoperative endoscopy or surgical exploration and fix the hyoid hernia. You don't want bile in that esophagus. Now, if the patient is coming for wet recurrence, of course, you really want to have someone talk to these patients to see if they have recurrence because they never followed up or other reason. And these people, for us, go to our very sophisticated medical weight management team. Now, if they're good candidate, they have the same workup. And now, this is here the controversy. And if they have abnormality in their sleeve, and they have bad symptoms, together, all these people will have Roux-en-Y gastric bypass. But I will stand here and maybe get beat by Calvin after this. If they don't have symptoms, I still can do an OAGB. If their abnormality is not that severe, but the patient is not symptomatic. I can stand here and tell you this is what I do and be criticized and learn. And now, after doing a bunch of OAGB and seeing my patient now for 2 years, if they have normal sleeve on EGD, so if they have normal sleeve on EGD, upper GI, and asymptomatic, strictly for wet recurrence, I can do an OHGB, and if the sleeve is dilated, we can always re-sleeve that pouch. And of course, make sure the hiatus is normal. So in conclusion, revision surgery should really not be taken lightly. For those of you who are young in the room, make sure you're prepared, make sure you know a lot about the patient, and please talk to the patient, see what their goals are, see how intelligent they are, see if they can afford taking their vitamins. Because if they cannot afford taking their vitamins, in the US, vitamins cost a lot of money. So make sure they can afford before you say, I'm gonna do the duodenal switch, okay? Be aggressive in the preoperative workup so you don't get in trouble. A lot of our post-operative poor outcome is related to poor selection. And lastly, having endoscope in the room, I think is very critical to have that and investigate the hiatus, and always be prepared for surprises in revisional surgery, because you're almost always gonna see something you don't expect. Thank you very much for the honor, and I'll take any questions.
Thank you, Rami, for that very
Except from
practical
Luigi.
talk. Yeah, I think we have time for questions. Luigi.
No, I think I realized that you are learning very well. Congratulations. Nice,
Jesus.
very nice presentation. Very nice. But I have one question. You have a beautiful algorithm. But what happens when you have esophageal reflux with the sleeve migration that was repaired, hiatal hernia at time of primary, or was not repaired, but with normal weight? I mean, people do not have problem of weight, but have problem of reflux, and they are basically normal weight patient. What do you do?
Thank you. That's a great question. That's like another debate. I think Camilo and I had that debate in France a couple of years ago.
Don't tell me links.
Yeah, there are people who do. I do not do it. There are people who do it, but I just want to make sure everyone knows. Now, for us, Luigi, again, as an American, we're bound by insurance. It is almost impossible to get approval to do a gastric bypass in those patients because they have normal weight. Even if patients have class 1 obesity and sometimes class 2.
Rami, I'm not talking of money. I'm talking of science, of
No, I'm telling you
medical
what we do.
approach.
Yes. So it's logistically, it's almost impossible. So what we do, to answer your question, we have taken a lot of these people and studied their sleeve. If there's no twist, if there's nothing that we think causing the reflux, and the sleeve is near perfect ergonomically, I believe those patients deserve a very good esophageal lengthening, dissection of the hiatus. Second time, you said it could have been done before. And I think if you put 2-3 centimeters of esophagus in the abdomen and make sure you do intraoperative endoscopy, Luigi, and make sure when you put air, the sleeve is not twisting. Sometimes you miss that twist. So if the sleeve is perfect, I believe hiatal hernia repair, short of gastric bypass, with good intra-abdominal esophagus, should have good chance to get rid of that GERD.
You said short gastric bypass.
No, lengthening without intra-abdominal esophagus,
Okay.
dissect the GE junction, bring it down,
Okay.
and do not do a gastric bypass.
Not do.
Yes, but this we found out that intraoperative endoscopy with blowing air in the sleeve can tell us a lot about subtle twist.
Okay.
And
So
if that's the case,
the
it's unlikely to get rid of
the
the
assumption
reflux.
is that if the JG junction is below the diaphragm and stay below the diaphragm, you do not have esophageal reflux. This is the theoretical assumption.
The hope, theoretically, yes, but practically, we don't know.
Kelvin, do you agree with that?
Luigi, short question, short.
No, only see Kelvin if I agree with that.
Agree with
With
just fixing
sli-
the hiatal hernia and that's it?
And leave it.
Yeah, I think it's worth a chance. I think it's worth a chance. I have one question for you.
Yes, sir.
If it's okay. What do you do, and this kind of goes along with what Luigi said. What if this patient has a BMI of 65, but a bad-looking sleeve? All right, twisted, kink. Do you have any tips and tricks for the audience on how you can salvage that situation? Go to a SADI, a DS, something you can do to the sleeve just to, instead of converting to a bypass? Because we know that that patient's not going to achieve, by their history, reasonable weight loss, right, with a bypass conversion.
Yeah, so the short answer is no, I don't know. I think if you have a bad sleeve, you can play with it, aumento pexi, do whatever you want. But I think if you're given sleeve that has a lot of problems, you know, it is time to go above and divert the acid and bile.
Question next. Rami, thank you very much. We have to go on in the program.
Thank you.
And it's my pleasure and honor to announce our next speaker, Professor Kelvin Higa from Fresno, California, former Big IFSO president. And I think he is one of the best speaker worldwide on that topic, I can imagine. Revisions after Roux-en-Y gastric bypass, what are the real options?
Thank you. I think what you're, anybody in the room has done an open gastric bypass? Oh, thank God, I'm not the, they have a young IFSOS club. I think we're going to have an old IFSOS club. So revisions after bypasses, this has been, you know, since around the late 90s or so, started becoming an issue. And back then, you got to remember, we didn't know about Gorilla and GLP-1 or hormones. We're thinking mechanical restriction, malabsorption. That's all we were thinking about. So I have a long history of modifying the pouch and that sort of thing. And I can tell you what my experience is, but unfortunately, most of this is going to be opinion. And the reason is because the literature on this subject is so poor. Short-term follow-up, heterogeneity of the subject, and we don't even know what a proper gastric bypass looks like over time. So the thing to remember is the gastric bypass is not a standardized operation. Everybody's pouch is different. It's configured differently, it's shaped differently, its volume is different. The reported outcomes after revision suffer from lack of follow-up and heterogeneity, and it's difficult to apply to the individual patient. Remember, we're not precision here. Every patient has an individual response to what we do. So in a sense, they all become their own experiment. But if we break down the anatomy of the bypass, you have the anastomosis, you have the pouch and the bypass, and can you make any sense of what we know from experience, right? We can do endoluminal treatments. We can size down the pouch and the stoma. We can revise the pouch externally, something I have a lot of experience. We can band it externally with an adjustable band or a ring or phobia operation. We can distalize, type 1 distalization, type 2 distalization we heard about, or we can convert to a big operation like a BPD-DS. Now, what the endoscopists will tell you is that the stoma is a big deal because they have this data and it keeps coming up, right? This is a 2011 article that correlates, without a doubt, weight regain with stomal diameter. But when I look at this, now if you take away the fancy line, I can see someone with a 20 millimeter stoma having either 0 weight gain or 100% weight gain. To me, I look at this data differently. To me, it's not the stoma size for most patients, even though there may be a statistical correlation. And a good randomized prospective trial of this would be comparing a 21 millimeter EA to a 25 millimeter EA. The only way you can really standardize a stoma, absolutely no difference after 3 years in weight. So what about the endoluminal treatment then? And the title of this paper even says it, endoscopic revision, holy grail or epic fail. This emulates what my experience has been in this subject, where I can do anything I want to that pouch. I can get great results at 1 year, but I've chosen to only publish 3-year data on revision data because of this, because there's a lot of patients that either don't follow up or they gain their weight back. And pouch size, if we look retrospectively on this, doesn't have any correlation with weight loss, only with marginal ulceration. And then you have a patient like this. This is a patient that I saw for possible internal hernia, and we explored the patient. And we, of course, we do endoscopy, and we find that this patient has a stomach pouch after a gastric bypass, about the size of the regular stomach. And yet, this patient had a BMI of 65 and comes in with a BMI of 24. That's almost unheard of performance after a gastric bypass. And what a crappy looking operation this is, right? And I guarantee if you try to downsize this, they're not going to have anything else going on. And so this kind of illustrates how much we don't know about what we do when we modify anatomy just for anatomy's sake. So this brings up, our old paper on type 1 distalization, and the whole idea behind this was we took a cohort of patients that we know were absolutely perfect because they followed up in our clinic forever. They were nutritionally intact, but they had one thing different. They had insatiable appetite, meaning that it was more biologic, not behavioral, at least subjectively. So what we wanted to do is divert more, make use of the hindgut theory, promote stimulation of the L cells, PYY, GLP-1, that sort of thing. And so we cut the rear limb here, plugged it in there. We have a 4-meter total arm length. And despite what the previous speaker said, this is probably the safest revision on a bypass you can do. Bar none. Now, a lot of these patients have to go back. That's why we handle the anastomosis, because we're always thinking we have to modify because we're just guessing here. And what did we find out? We found out that the patient had significant weight loss. But look at these numbers. These were hand-selected by me. And at 3 years, I only had a 50% follow-up. Right? So it's pretty hard for me to say anything about how well and how durable this thing is. All we know is that it does impart greater nutritional deficits. There's a significant response, especially for type 2 diabetes, and the weight loss for some patients was outstanding. But the problem is we can't predict who's going to do well and who's not going to do well. All right? And then now you have these papers, which is really interesting. So this is looking at GLP-1, postprandial GLP-1 response after eating, and it turns out, looking back and analyzing all these things, that a shorter root limb has a greater postprandial GLP-1. The BP limb length has no effect. Now, this kind of goes against all the things that we're thinking about right now with the BP limb and more distalization, is better diabetic effect and all that. So this brings to mind, if we have diabetes, should we make the root limb really short? I don't know, right? We have all these confounding articles. So again, the distalization it's just an easy operation because all it is a transection, one anastomosis, close the internal hernia space, and that's it. It's a small bowel anastomosis. And in anyone's hands, a small bowel anastomosis has pretty low risk compared to a pouch revision, that sort of thing. And that's it. But something more complex, and if you really want to go after weight loss, significant weight loss, that means we got to take this bypass to something totally different. We can't just fool around with the limbs, can't do some of the pouch. We got to change it to a more significant operation, a SADE or a duodenal switch. Right? So that means taking apart everything, redoing the small bowel anastomosis, putting the stomach back together again, transecting duodenum, bringing up a loop and sewing it together. Now, the problem with all these conversions, no matter what you read, you can't, nobody really does a formal sleeve gastrectomy after taking down a gastric bypass. And the reason why is the blood supply just doesn't support that anastomosis. I can tell you why, because I tried. So if you do that and you take down all the antral vessels and make a nice tight sleeve that looks really good, it's going to leak 40% of the time, just because of ischemia. So we always do this as a stage operation. These operations are at least 2 or 3 different stages over the time. And we have to make sure that when we put the stomach together, we line up that lesser curve so that we can go back in and re-sleeve and make that sleeve look nice. Because sometimes you take them from a RITAS to a SADE to a DS and you still haven't hit the mark and you still got a great big ugly looking stomach that you can do something with. All along trying to figure out how you're going to avoid all that reflux, because they are going to have reflux by definition. Right? It's just how much can they tolerate. So once you put it all together, and this is why I think that there isn't really a place to just blindly staple things together, that the only way I can do this operation effectively is to open up all the staple lines and to line it up manually, just manually sew it. And most of the times I'll do this in 2 layers, excising the staple line a lot of times, sometimes not. But in that way, I can get the stomach at least to lie in so I can think about the next operation that's going to be creating a real sleeve gastrectomy. Okay, so this is our data, our preliminary data unpublished. We had 48 patients that we converted to a SADI, 22 to a DS, and they all did really pretty good over time. There was no real difference between the weight loss, no difference between the complication rates between all of them. All the vitamin levels were about the same as well. And this contrasts with this study, which is only 15 patients, where they saw a significant difference between the DS and the SADI. So in our population, in our patients, our SADIs and our DS appear to be rather equal. And of course, Ron has already talked about, when we're talking about gastric bypass, really, we're not really revising these patients for weight problems, and mostly for complications, because the GLP-1s do such a good job with these patients. It's safer, and it's more predictable. So final thoughts. The GLP-1s really are primary treatment for weight gain after gastric bypass, and it's good for dumping and alcohol use disorder as well. The pouch and stoma size banding has been really disappointing for me. Type 1 distalization produces moderate weight loss, but significant nutritional issues. And the SADI-DS gives us the best results. But this is a hard operation. These patients, I mean, there's complications, and these patients are looking at 2 or 3 different operations. Thank you.
Thank you very much, Kelvin. Great talk. First question, Camilo.
Very nice talk, Kelvin. But I saw your data, and you had 24% total weight loss for the type 1 distalization and 25% for the SADI. Why would you do that?
Well,
That
Yeah.
you showed the data, 25. The number was always, it's always, and when you see Torres' data for revision on SADI, 25, and that's it. It's not more than that.
well, it's a good question. But so the real to tell you the truth, I mean, we're talking about different subpopulations, right? So the type 1 distalizations are generally patients with BMIs less than 50, okay, number one. The DSs are always BMIs over 60 in a way, okay, because we know that they're just over the top, and no matter what we do, we can't get them down to a certain level. But you're right. I mean, you look at the endpoint of all these revisions are about the same on paper. When you look at the patient, though, it's a little bit different. Okay, that's what I can say.
So you,
And then it's an average, right? And we're talking 50% fall up on that one side.
on the
And
side
this
it probably is similar. But today, which is your decision to do a type 1 distalization or a SADI revision?
It depends on the patients, it depends on their needs. If they're lighter, and I'm going more after metabolic issues, then I'll go with a type 1 distalization, especially if they had a preoperative reflux situation. Right? If they're coming in and they already had a BMI 60, 70, they had a gastric bypass, and they had some performance, they gained their weight back again, and they're not having a lot of reflux, then I'm going with a SADI, just because.
Okay.
Which limb lengths do you use in SADIs? 250 or 300
250.
for revisional? And
But
if
I'm
you
sorry,
if you
the,
do
the
it
revision for the SADI is 3 meters. So
3 meters, yeah.
And which is the same with the type 1 distalization.
That's why we're saying.
But the thing you
And
don't
less
get,
complications,
the thing
huh?
was, what you don't get when you have a SADI, though, because of the intact pylorus, you do have less, in my anecdotal experience, much less diarrhea,
Okay.
steatorrhea, and things like that. Right.
Thank you very much. And we go on in the program. Our next speaker is Mario Nora from Portugal. Mario will talk about OEGP, SADI, and BPDS. We come now to the powerful tools or too much risk.
Good afternoon, ladies and gentlemen. It's really a pleasure and an honor to speak at this IFSO meeting in a topic that are at the boundary between innovation and prudence. OIGB, SADIS, and BPDDS powerful tools to match risk in context of revision and conversion surgery. I have no commercial disclosures. And why this topic? We are all seeing more patients with failed primary surgery, insufficient weight loss, weight regain, and complications. At some times, expectations for durable weight and metabolic control are higher. In this setting, some of us consider these bigger operations. And why even consider these big operations? They offer a strong metabolic effect and more durable weight loss than many standard revisions. They can be useful when classic options such as bend to Roux-en-Y gastric bypass or sleeve to re-sleeve are unlikely to work or already failed. They are particularly attractive for severe or super obesity, refractory type 2 diabetes, and multiple prior failures. They are not first-line operation, but sometimes they can rescue very difficult cases at cost of a higher complexity and nutritional risk. So let's start with OGB, the one anastomosis gastric bypass that creates a long pouch and a single loop gastrojejunostomy and colic with a biliopancreatic limb, usually between 150 or 250 centimeters. As a revisional procedure, it is commonly used after failed sleeve or failed Roux-en-Y. In some revision cases, it can be simpler than Roux-en-Y because it's just one anastomosis and no jejunostomy. It usually gives a good additional weight loss and control of diabetes, and in experiences and can be operative time can be shorter than the Roux-en-Y gastric bypass. The main concern are bile reflux, that is rare, but in a minority of cases is severe enough to need conversion to Roux-en-Y. The other concerns are marginal ulcers, especially in smokers and non-steroid anti-inflammatory drugs user, and protein and micronutrition deficient if the limb is too long or the follow-up is poor. So OGB is a powerful, relatively straightforward option, but limb length, reflux risk, and nutrition can be carefully managed. SADI or SADI-S preserves a sleeve-shaped stomach and adds a duodeno-ileal bypass with a common channel, usually between 250 and 300 centimeters. It became very popular as a second step after failed sleeve. It can be in one stage or two stage, depending on the BMI and the risk. We keep the sleeve and add a strong hypoabsorptive component with only one anastomosis, which is very attractive in revision. SADIs offer a strong metabolic effect with good results, but weight regain and diabetes after weight regain and diabetes after sleep, and is generally better tolerated nutritionally than the historical short channel duodenal switch. Although it's considered an hypoabsorptive technique, in our experience, and you're using normally a common channel of 300 centimeters, malnutrition, vitamin deficiencies, and diarrhea are extremely rare. So SADIS is an excellent option for failed sleeve with high metabolic needs, provided there is a strict nutritional surveillance and patient's adherence. BPDDS, the classic duodenal switch, combines a sleeve-type gastrectomy with a duodeno-ileal anastomosis and a separated biliopancreatic limb with a short common channel, often between 75 and 115 centimeters. As a revisional procedure, it is usually reserved to extreme obesity, severe metabolic disease, or multiple failed operations, and shall be performed only in high center volume centers. Its benefits are well known. Among the best results for total weight loss and the remission of diabetes and dyslipidemia with durable long-term effect. Major risk is that it carries the heaviest nutritional burden. Protein malnutrition, iron, calcium, and fat-soluble vitamins deficiency are frequent without excellent follow-up. Some patients need elongation or lengthening of the common channel. It is technically complex with longer operative times and risk accumulation in revision cases. So BPDDS is extremely powerful, must be reserved for only select patients in the experienced centers. And how do you choose? First, we must clarify the indication. Weight loss only, severe metabolic disease, or anatomical or functional complication. A failed sleeve with weight regain may be better candidate for OAGB or SADIS. A band with esophageal issues may be better served with Roux-en-Y gastric bypass or OGB. How do you sorry. After that, we must thinking about patient profile, BMI, eating behavior, adherence to follow-up, age, comorbidities, frailty, plans, pregnancy plans, psychiatric and socioeconomic factors, ability to comply with supplements and labs. Third, consider surgical history and current anatomy, number of prior procedures, adhesion, GERD, hiatal hernia, scar tissue, and so on. Finally, look honestly at the center expertise and capacity for long life nutritional and psychological follow-up. So, in my view, these procedures become too much risk when there is no guarantee of long-term follow-up, when the patient is unlikely to comply with supplements and labs, or when they are performed in low experience settings, especially with very short common channels. They are powerful tools when indications are strong. They are done by experienced centers and nutritional protocols are robust. So, to summarize, OIGB is a good revisional choice after failed sleeve or band, but biliary reflux and limb length are key. SAD is excellent for failed sleeve with high metabolic needs, with better nutritional profile than classic DS, but still clearly hypoabsorptive surgery. BPDDS gives the maximal metabolic effect at the price of the maximum complexity and nutritional burden and should be reserved for selected cases. Ultimately, in revision surgery, the best operation is not the most powerful, but that one that is powerful enough and realistic, safe for that patient and for that team. So, OIGB, SADIS, and BPDDS, powerful tools when they are used wisely, too much risk when used indiscriminately. Thank you.
You know, it seems that the more powerful operation is really dependent on our trust of the patient to follow up, take their vitamins, and do the right thing. But that's even in the beginning, with all of bariatric surgery. In fact, our standards were we shouldn't operate on anyone who is unreliable, non-compliant, doesn't follow up. So in my practice, when I've proven that I only have 15% follow-up at 10 years, by definition, I shouldn't operate on anybody ethically, right? And I may be the only one in the room with this problem, but we say these words, but we don't stand by them, because we know we operate on people that we know they're not gonna follow up, right? How do we get over this ethical dilemma?
Well, in Portuguese, the health system is different. So you must see all the operated patients forever.
Different systems.
They don't pay, yes, of
But
course.
do they come?
My
Mario-
patients- my
But
patients
it's our
don't pay
system.
either.
Mario, do they come, even if it's for free?
No.
Yeah.
No. It's a percentage of cases they don't came. But if they don't came, we don't have the money.
Yeah.
So we must phone to the patients and ask them to came.
Understood.
Thank you. That's a wonderful talk.
Wait, Luigi, let's follow, please.
Thank you, Luigi. Now, you said a lovely thing at the end. Even free patients who come for free follow-up, they don't come. There's a huge issue of compliance with the patients. And I, for one, for 90% of my work for bypass the last 24 years. I mean, I took a cue from the Americans. Kelvin Higa came to our place, and then it was interesting, 90%. I'm slowly changing to sleeve now, more of sleeves coming through. The problem here I find is, all of us are changing over a quarter of a century now. We've done a lot of changes in what we do. The question is, with sleeve becoming the most popular operation, nearly 60% of the world, can we improve on the sleeve? We know, we have seen the first two speakers telling us about the recurrence rate of a hiatus hernia or a reflux is ranging between 20 to 40% weight gain. And nearly after 4 or 5 years, we got a large number of people going in for revisions to bypass some of the procedure. Can we look at improve sleeve? I, for one, start a small thing like suturing, like the Brazilian technique of suturing the top of the fundus of the stomach, the angle to the left crust, and doing omentopexy with the view that it may reduce the twist or hiatal herniation or reflux. I'm not sure it's the right thing to do. What do you think? Can we improve the sleeve instead of going for the much wider operations and the bigger operation? Now that we're all going for sleeve, even Kelvin has moved to sleeve. That's a surprise to me.
As long as we have no data, this is eminence-based medicine and not evidence-based medicine. So I would suggest to do proper studies and come back with data.
In a couple of years' time, we've got 5 years data coming back in 5 years.
And yes, at least 5 years data. I have one last question for you, Mario. You mentioned in the OEGB the length of the BP limb 150 to 250. When would you consider to go beyond 150? And is it mandatory to count the entire small bowel if you go beyond 150?
Never, because I don't do OIGV.
Okay, so
I
I would say even if you do, you can also do a Roux-en-Y with 150 BP limb or even longer. There are people doing that. I would strongly recommend, not suggest, when you go with your BP limb length beyond 150, you must count the entire small bowel length.
Yes, we do in patients with metabolic issues. We normally use biliopancreatic limb of 200 centimeters. And when we do this, we count on this.
That's fantastic.
Because sometimes we have surprise.
Exactly, yeah. Okay, thank you very much. We go on in the program. Let's have a look what the evidence is for gastroduodenoileal procedures in conversion surgery. If there is any evidence, André Pinho from Portugal. I'm really curious now.
Good afternoon, everyone. My name is André Costa Pinho from Porto, Portugal. Thank you for the opportunity to discuss the evidence for gastro and duodenoileal procedure in conversion surgery. I feel like I'm going to try to summarize some of the information already discussed and add some new information. I have no relevant disclosures, and this is my case mix. For this presentation, I reviewed 28 articles, including systematic reviews, consensus statements, and original studies. For the sake of time, I will focus on weight loss outcomes after revisional ileal procedures. However, I must acknowledge that the global assessment of any metabolic surgery should also consider improvement of obesity-related disease, perioperative and long-term complications, and quality of life. I will briefly cover the following topics. So what defines an ileal procedure? It is any metabolic surgery that creates an anastomosis to the ileum, bringing food directly into the distal small bowel. The key advantage is in-gut stimulation that improves satiety and glycemic control through enhanced incretin response. Bile acid modulation and hypoabsorption also have a role. Revisional surgery is a growing reality. In the United States, there was a 60% rise in revisional procedures in the last decade. Sleeve gastrectomy, the most common primary procedure, is the main driver, with recurrent weight gain being the leading indication in over half cases. It is important to clarify some definitions. Recurrent weight gain means late weight regain after initial good response. Suboptimal initial clinical response is defined as less than 20% total weight loss or worsening of any obesity complication. And we should distinguish between revision, modifying the same procedure, and conversion, switching to an entirely different operation. These conversion procedures accounts for the majority of revisional bariatric surgery. When we look at ileal procedure in the revisional setting, there are essentially three concepts. First, pylorus preserving procedure with exclusion of duodenum, like SADS. This procedure have the most evidence after sleeve gastrectomy and potentially lead to less dumping and hypoglycemias. Second, procedures that preserves pylorus and duodenum, like transit P partition. These maintain full gastrointestinal continuity with no excluded segments. Third, procedures where both the pylorus and duodenum are excluded, like distalization of a previous Roux-en-Ipsen gastric bypass or long BP limb Roux-en-Ipsen gastric bypass. These are relevant both for conversion after sleeve and for revision of a prior bypass. They also address GERD and hiatal hernias. Before we look at any outcome data, we must acknowledge several limitations regarding surgical technique variability, namely limb length, inconsistent outcome reporting and definitions, ambiguity in baseline weight before primary surgery or before revisional surgery, and patient selection bias, indications, and timing of revisional surgery. Looking at the evidence for SADS and the duodenal switch after sleeve gastrectomy, this is the category with most published data. As you can see in this slide and the next one, there are multiple studies from individual cohort ranging from 42 to 141 patients to systematic reviews pulling over 400 to 1,000 patients. The reported incremental weight loss after conversion varies widely from about 9% to 42% of total weight loss, reflecting differences in follow-up, common channel length, and whether a re-sleeve was performed. The pooled data from meta-analysis, and I must compliment the article published last year by Ana Marta Pereira, my colleague from Portugal, that reports an average of 27% total weight loss at 2 years. Importantly, two expert consensus both endorse SADS as a good revisional option after sleeve, with agreement rates above 88%. However, I want to highlight three concerns. First, long-term data remains scarce. Second, SADS as a conversion after sleeve consistently yields inferior weight loss compared to primary SADS. And third, revisional surgery, particularly conversion from sleeve to SADS, may carry a higher risk of perioperative complications. Just to show on the left that the duodenal switch appeared to achieve superior long-term weight loss compared to SADS, but at the cost of higher nutritional deficiencies. On the right, SADS clearly outperforms conversional Roux-en-Ipsen gastric bypass on weight loss outcomes. Moving to transit P partition after sleeve gastrectomy, the evidence here is more limited. We have studies involving 24 to 171 patients, with incremental weight loss ranging from about 5% to 30% total weight loss. The variability is substantial, again, due to differences in anastomosis size, common channel length, and concomitant re-sleeve. Notably, the Delphi consensus did not reach agreement for SASI as a revisional option. So, while early results are promising, the level of evidence remains weak and expert consensus is not yet supportive. Transit P partition remains a promising investigational bariatric procedure. Interestingly, this article from Germany compared 3 variants of transit bipartitions after sleeve gastrectomy: one anastomosis transit bipartition, Brown transit bipartition, and Ruan-Ipson transit bipartition, with 57 patients in each arm. At 2-year follow-up, weight loss outcomes were comparable across all variants, with an incremental total weight loss of 12 to 13%. Gastroileal procedure can also be an option after gastric bypass. Here, BP limb length, BP limb distalization is the key option. We have studies with 22 to 96 patients reporting incremental total weight loss ranging from about 17 to 35%. The critical technical question is limb length. Early series with shorter total elementary limb lengths of 250 to 300 centimeters reported high rates of malnutrition, up to 64%. More recent protocols using a toll of 400 centimeters or more show better nutritional safety. The Delphi consensus is clear here. BP limb lengthening is the only procedure that reached consensus as a revisional option after Ruan-Ipson gastric bypass, and it is also the only consensus option after OAGB. The results from this study with 90 patients revealed acceptable results even after a follow-up of 8 years. A total of 300 centimeters was advised because the weight outcomes were similar with less nutritional deficiencies and malnutrition when compared to a total of 250 centimeters. Briefly, our experience at Hospital São João in Porto, where 17% of our caseload is regional surgery. These are unpublished data previously presented at other meetings. We have performed 27 conversions from sleeve to SADS, achieving an incremental total weight loss of 18% at 2 years. We have also begun performing SASI as a conversion procedure after sleeve, 9 patients to date, with an incremental total weight loss of 90% at 1 year. A prospective study on SASI outcomes is currently underway, approved by our ethics committee. Finally, 13 patients underwent BP limb distalization after prior Ruan-Ipson gastric bypass, achieving an incremental total weight loss of 24% at 2 years. All these results are consistent with the published data presented earlier. So, how do we choose the right ileal procedure in the revisional setting? After sleeve gastrectomy, SADS remained first choice for weight regain without reflux. It carries the strongest evidence. When GERD is a concern, Ruan-Ipson remains the gold standard. A longer BP limb may be considered. Transit bipartition is a reasonable alternative in an investigational setting, especially when preserving gastrointestinal continuity matters. For instance, when future endoscopic biliary access must be maintained. After a prior Ruan-Ipson gastric bypass, BP limb distalization has consensus support. But important questions remain unanswered. What are the optimal limb lengths? Should they be fixed or individualized to each patient's anatomy or BMI? And should we routinely enhance the restrictive component with a re-sleeve? Regardless of the procedure chosen, malnutrition is the principal risk of ileal surgery. My strongest recommendation is always measure total bowel length intraoperatively and leave a common channel of at least 250 centimeters. These patients require lifelong supplementation and frequent laboratory monitoring. That means selecting patients who are well-informed, financially able to sustain supplementation, and willing to attend regular follow-up. And finally, some of these patients will require reversal surgery to manage severe malnutrition. Patients must be warned of this possibility before they consent the procedure. To summarize, ileal procedures enhance outcomes through distal gut stimulation and some hypoabsorption. The overall quality of evidence for revisional ileal procedure remains low, with high heterogeneity and lack of standardization. Nonetheless, SADS has the strongest evidence after sleeve. Transit bipartition is promising, but still have limited evidence. After Ruan-Ipson gastric bypass, BP limb distalization is the only consensus option in this setting, and procedure selection must be individualized, considering several variables. Thank you very much for your attention.
Thank you very much. One simple question. You had in the slide the distalization after Roux-en-Y gastric bypass, and you recommended to have a toll of 3 meters. So if you have now an elementary limb of 150, what would the length of your common channel be?
When I was reporting, I was referring to the study that recommended
Yeah.
a tall of 300 centimeters. It's not our
Yeah,
practice.
because I think this is much too short. Kelvin
Yeah, of
published a
course.
very nice paper, and I would consider, but maybe you can talk about
Right,
it.
so when we did a tall of 3 meters, we found we had to revise 100% of them for
Yeah, of
mountain
course.
vistas. So that's why we went to 4 meters pretty
I was
quickly.
citing an article.
Yeah.
I don't.
Yeah, just to clarify
Okay.
that. Yeah. Francesco.
A very quick clarification, just from the semantical point of view, a little bit provocative. I've seen in your first slides, you say it's not malabsorption, it's only energy and fat hyperabsorption. I just don't understand it. I think it's the same. We are just naming two different things, the same thing in two different ways.
Yeah, what I meant it was to focus on the enhanced incretin response. That's the main focus, in my view, with the ileal procedures, and not focusing in the hypoabsorption or malabsorption, because it makes sense to think this way and to preserve some ileum, because we don't need the malabsorption.
One more? I said Luigi. All right, Luigi, but short.
As I understand, you have performed SASI and Rouen-Y transit by partition. What would be your result in case where for the treatment of esophageal reflux after sleep without need of weight loss? Would you consider it having performed this operation?
The short answer is no. When there is GERD, it's mandatory to convert to an Ipsen gastric bypass. But in mild cases like esophagitis grade A or without any hiatal hernia, you may consider a SASI. Yeah. But
SASI, not Rouen-Y.
transit repartition
Transit.
in each variant. Okay, but not in the profound GERD disease.
Thank you.
Thank you very much.
Thank you. Thank you.
I think our next topic is better laparoscopic robotic approach. And I think we have a pinch hitter, right? You're not one?
Yeah. No, I'll be representing Santi from Luxembourg.
All right.
I-
What is your name?
I'm Benji Pascotto. I
Okay.
work with him. He's my mentor, and I bring 10 years work with him. And so the message will be the same, just
No,
from
no. No. We have to give credit where credit is due. We want to know who you are, and thank you for filling in. This is the equivalent of docking the robot.
Maybe in the meanwhile, who is doing robotic metabolic bariatric surgery in the room? So still the minority. In the US, I think it's this year above 50%, Kelvin.
It's above 50%, I think,
Yeah.
now.
But Europe is gaining. And who is doing 100% of his work robotic? Ah, interesting. Okay. So nobody, as far as I can see. Yeah. Who is convinced that robotic is better than laparoscopic in MBS? Who is convinced that there is no difference? Okay. And who thinks laparoscopic is better? Okay.
But better for who?
Yeah, that's a
Not
good
the
question.
surgeon. Not the surgeon, for society.
Okay. Can you start your talk?
Yeah, but this.
Just a little bit. You know, okay, so while we're waiting, so hypoabsorption,
Yeah.
you know, I'm thinking about some of these distal types of bypasses, and we're trying to alter the hormones, but as a bad side effect, we're imparting diarrhea and steatorrhea and things.
Collagenic diarrhea.
I'm wondering if we can somehow avoid it, but also get the stimulation. Camilo, you had a comment?
but concerning the question you said about saying that because your patients, you were converting to SADI, those patients that had BMI over 60. So basically what I understood from your answer was that even data shows the same 25% everybody has shown after revisional. You, even considering that, you are taking the risk of putting together again the bypass to perform a sleeve, even in 2 stages. And so I still don't understand the rationale for that. And I know because basically we have been following that paper of 450, and we usually do a 150 alimentary limb, so we tend to use 3 meters of common channel, and with that we don't have diarrhea, and we have the same 24%, and I'm not sure if that really matters if the patient is a BMI over 60 or
Yeah, and this is where your data, right, can mislead what's really going on in the real world, right? Because obviously every patient isn't just said, okay, you're going to get this distalization and everything. And, you know, there's something magic about pylorus. Gerhard and I were talking about this. You know, the gastric bypass has innate problems we really haven't talked about. Postprandial hypoglycemia, neuroglycopenia, all these things. And when you put the pylorus in there, it seems to mitigate all of those digestive issues. I mean, we've seen patients that, you know, in my opinion, when I'm really trying to go after, and once again, I'm not trying to, I'm trying to emulate what we know about the existing operations. We know the results with DS. We know the operations of the results of a SADI. And I'm converting a patient over whose the operation failed them, essentially, right? And imparting quality of life and longevity that we still haven't proven with these operations, right?
But my issue is that we still are waiting, like the pylorus, this miraculous pylorus. Antonio talks about that every day, but I still am waiting for one paper saying that the pylorus is really making a big difference in evolution of those patients. It looks like it sounds reasonable,
Yeah,
of course.
Pretty hard to design a trial that looks just at that, I suppose. But,
Thank you.
but maybe you can do it.
No, I won't. Definitely I won't.
All right.
Go ahead.
Excuse me. I'm sorry to insist in this same question, but do you believe that...
Please identify yourself.
I'm Ana Marta Pereira. I'm from Portugal.
Thanks.
And my question is, do you think when you convert Roux-en-Y gastric bypass in a SADI-S, do you think that the pylorus will work the same? Because you transect the vagal innervation. So I'm not sure if it's the same work.
No, we're pretty sure it doesn't work the same. I mean, even if you preserve the vagus nerve on the first operation, by the time you do a conversion, you can bet that that vagus nerve isn't working. But then the stomach isn't the same either. The fundus is gone, the capacity is less, and when we do endoscopy, we always do, we make sure it's wide open. We just haven't seen the issue with pyloric dysfunction or stenosis that you often see with esophagectomies and things like that. Fortunately, we haven't had to do that because we like the pylorus. We don't want bile to reflux up in there and cause other problems. And you don't want to go from a bypass to a SADI back to a bypass. That would be bad form. But I've done that.
But that's, of course, the maximum on revisional surgery you can do. I mean, so I think the message should be maybe converting a bypass to a SADIS is really something, this is for somebody like you.
No, it's not for anybody.
Yeah, maybe that's a better,
It's
message.
true. I mean, it's one thing to...
Wait, Luigi, go to the microphone, please. Wait, go to the microphone.
So I want to make it clear to everybody. When I said it's an experiment, it is an
No,
experiment.
but tell me, when you convert Roux-en-Y in gastric operation and go in for doing the SADI, why would you not consider doing a SASI? Because it would be much easier to not going to dismount the pylorus and just doing a transit by partition, what I'm saying.
Yeah, I understand. I just believe that in this operation, having the pylorus intact gives us better livability with the operation. That's what I believe.
So you think SASI, you leave the pylorus in SASI?
Yeah. How are we doing over there?
Finally, we have some technical problems we cannot solve. It's of course a pity because we stayed pretty precisely in time, and I think we have to close the session. In this case, you have a longer break. Enjoy the break. Thank you very much.